Good afternoon, everybody. Welcome to the noon meeting. My name's Lucy Johnson. I'm the head of the Health Policy and Systems Division. This is one of the HPS Division's noon meeting seminars, and I'm really delighted to introduce Amanda Edwards, who has just completed the MPH and Health Systems track and is now with the Cancer Research Initiative. Great to have Jenny with us here today as well. And it's a really nice opportunity to hear from Amanda about her dissertation work, which was done with Jill and Virginia, and thank you to the two of you for your support to Amanda, and which is on a really important topic of how research and policy making and managerial decision making interact or not. So I will let Amanda take us forward. Thanks so much, Amanda.
Thanks, Lucy, and thank you very much all for coming. It really is a pleasure to have this opportunity to present my MPH thesis results to you. A project on knowledge translation that doesn't get to translate its knowledge, would rather be like a cake that only I got to eat. So there is cake, but it'll come up there. So why knowledge translation? So I'd like to begin with scratching out two pretty well-known public health narratives for you that highlight the importance and impact that knowledge translation can have, or the lack thereof can have, on our understanding and practice of healthcare. But first, let me take you back to 1753, when a Scottish physician by the name of James Lind discovered that, empirically discovered, he was also attributed with the first controlled trial, that by giving sailors citrus, they could be cured from scurvy. Until then, hundreds of thousands of sailors had died of this disease, and it had been a real scourge for the British Navy. But despite this very clear evidence that this worked, and the fact that he disseminated his research through a very widely published book, The Treatise of Scurvy, Dr. Lind's results were completely ignored until the late 1700s, when finally the British Admiralty decided to administer lemon juice to their sailors. Let's fast forward a century later, and in the 1840s, a Hungarian doctor working in Vienna named Ignaz Semmelweis empirically discovered that washing your hands before delivering a baby could reduce maternal mortality rate by over 80%. Surely this would be a done deal. You'd think that evidence like this would be taken up rapidly through the known world. But unfortunately, it's not the case. And despite hand hygiene being one of the most useful public health strategies to prevent the spread of disease, the first national hand washing guidelines only appeared in the 1980s. This is over a century after Semmelweis' discovery. And the WHO published its first hand safety guideline only in 2009. So, surely this is not the case now. Surely in this age of digital technology, where we can send our research to the furthest ends of the earth by a click of a button, we don't have to wait for 50 to 100 years before we actually get known interventions into policy and practice. But unfortunately, this is the case. And in a recent study in 2011, that was published by the Royal Society of Medicine, they discovered an average time lag of 17 years between known proven interventions being implemented into research, into policy and practice. The implications of this: delayed access to proven interventions that improve and save lives, policy and practice decisions that are not evidence rooted in up-to-date evidence, unnecessary inefficiencies, decreased quality, and most likely quantity of life. So KT is important. But what exactly is it? And I think we'll start to hear some of the theoretical reasons for why there is a persisting gap between knowledge, practice, and policy. There are over 90 different terms to describe a similar thing, and almost as many models to describe the same. And for this study, though, we used a commonly used Canadian Institute for Health Research definition, which states that knowledge translation is a dynamic and iterative process, not a once-off process, that includes the synthesis, dissemination, exchange, and ethically sound application of knowledge to improve health, provide more effective health services and products, and strengthen the healthcare system. In essence, it means getting the right information to the right people, in the right format, at the right time, in the right place, in the right way, to influence policy and research decision-making. But despite this increasingly complex and prolific nature of knowledge translation, there remains relatively little understanding about what knowledge translation mechanisms exist and what work in specific contexts, especially in our low and middle income settings. And this has perpetuated the know-do gap with significant consequences for health, policy, and systems functioning. In recognition of this, the Western Cape Department of Health established a project to improve how research was feeding back into their policy processes. And this study forms the initial part of that project. The primary aim of the study was to provide a contextualized understanding of knowledge translation, mechanisms that are used by both local health researchers and provincial health policymakers in the province. It is a study that's run concurrently with a fellow study that is being done by a colleague that's just walked in, who's looking at specific similar issues, but specifically within health facilities. And the purpose of the study was both exploratory and explanatory, and it targeted a macro level of analysis, but also with cross-cutting elements that considered individual choices in knowledge generation, dissemination, and utilization. The research question asked what mechanisms are used for knowledge translation by both health researchers and policymakers in the Western Cape, and how do these mechanisms influence the movement of health research into provincial health policy. The study design was a convergent parallel mixed methods design, where data was collected in parallel, analyzed separately, and then merged to provide a holistic understanding of how knowledge translation mechanisms and their role influence the uptake of research into policy. This figure provides an overview of the design and has a look at the data types that were collected, the collection and analysis methods, and the data synthesis and interpretation. If we have a look at the quantitative stream, what we did was we looked at a retrospective database review conducted using the National Health Research Database. This is something we're probably all familiar with, as we would have had to register our studies within the province, but it also forms the main repository for health-related research in South Africa. We sampled 300 studies from a total of 1,008 studies on the NHRD that were registered between September 2014, which was when the NHRD was created, right through to September 2016, which was when this project was conceptualized. The number of studies that was reduced we had to reduce the studies after we eliminated duplicates and studies that hadn't received approval. And after that, there were only about 100 studies left for analysis, so it was a bit difficult to work out any statistically significant associations. The variables we extracted from that database included the study title, the topic area, the study design, location, principal investigator, expected duration, proposed dissemination methods, and any explicit policy intentions. The qualitative stream, we combined a mapping review of the knowledge translation research across African health systems, including a document analysis of 17 relevant policies, grey literature, and journal publications, and then 9 key informant interviews with experts, including 5 health policy and systems researchers and 4 high-level provincial policymakers. We had initially targeted a more diverse range of health researchers, but unfortunately, due to a lack of response, it ended up being only health policy and systems researchers. So the interviews explored a variety of things, including what KT mechanisms were preferred, the perceived impact of these mechanisms, their barriers, and their facilitators. And any additional information that was gathered looked at knowledge flows, participant preferences for KT, and specific contextual factors. The interviews were transcribed verbatim and then cross-referenced to find common findings across data sets. Each data set, as I said, was analyzed separately and then integrated by cross-referencing common findings, and then a narrative account of the integrated data was presented. The guidelines for good reporting of mixed method studies was applied to ensure rigor for the study. And here is a photograph of that integration process with a little help from my research assistant, but I think he's actually looking more to go for a walk than help me. In the presentation of the findings, we're going to focus on context, specific KT pathways and mechanisms, the barriers that facilitate knowledge translation in the province, the facilitators and barriers that influence knowledge translation, and then also the use of research. But let's have a look at context first, because this really sets the stage for knowledge translation. Firstly, when we have a look at context, we've divided it into 4 specific things: the broad socio-political context, the provincial health systems context, the local health research system, which we'll discuss in a bit of detail, and then specific challenges that are cross-cutting with these. Firstly, for those who are not familiar with the Western Cape, this forms one of 9 legislative provinces in South Africa, and then in a 3-tiered system of governance. The province has substantial sway over local policy processes, but remains subject to national policy and funding decisions. The province consists of 5 rural districts and 1 urban district, excuse me, where all provincial, tertiary and public health facilities and research institutions are situated. The province has been led by the Democratic Alliance since 2009, And this has created somewhat of a political disconnect with national government, which is being controlled by the ANC. The health systems context, excuse me, in the health systems context, the provincial health system has been subject to ongoing reform since the early 1990s. And this has resulted in a rich, complex policy environment with over 100 policies relevant to Department of Health functioning. These are a list of these key policies over this time period that are relevant to knowledge translation. And a key theme that came out across these policies was the fact that research is needed and valued in policy making. The 2001 National Health Research Policy in South Africa mandated the creation of a Provincial Health Research Council, as well as the National Health Research Database that was used in this study. In the Western Cape, the Provincial Health Research Council has been tasked with the oversight and facilitation of health research in the province, and has also been asked to advise on policy implications of completed research. The Health Impact Assessment, which commissioned this study, acts as the secretariat for the Provincial Health Research Council. There are specific health system challenges, which I'm sure many of us are familiar with, including the persisting fragmentation of primary healthcare services, chronic disease burdens, including rising non-communicable diseases, aging infrastructure, and medicine supply shortages. These challenges also occur against a backdrop of widening inequality and mounting budgetary constraints. Furthermore, despite a rich legislative framework that's present, there is still currently no policy to guide nationally or locally to guide the translation of research into policy and practice. Having a look now at the local health research system, this system exists at the intersection between the health system, which is governed by the Department of Health, and the research system, which is governed by the Department of Science and Technology and the Department of Higher Education and Training. Its core reason for existence is to generate and utilize the generation and utilization of research-based knowledge to improve health and equity. In the Western Cape, health research system is extensive, with over 6 institutions that are not only sophisticated, but accredited with providing good quality, rigorous research. The translation of this research into policy is enhanced by additional institutions that have been created specifically towards synthesizing and using evidence. And these include examples like the South African Cochrane Centre at the MRC, the Knowledge Translation Unit at the Lung Institute at UCT, and the Centre for Evidence-Based Healthcare at Stellenbosch. Together with the Provincial Health Research Council, these institutions form a very dense network of policymakers and researchers across the province, and that holds a lot of potential for knowledge translation. But there are challenges within the system too, and we've experienced some of them ourselves. Persisting hierarchical and siloed organization, heavy reliance on donor funding, excuse me, and a continued orientation towards biomedical perspectives impede health researchers' abilities to respond to local needs. Additionally, research institutions themselves are facing challenges regarding their financial viability and their operation, as following persistent calls of fee-free decolonized academia. But now that we've set the stage for KT in the province, what mechanisms are actually used by the researchers and provincial policymakers? And I just want to be clear here, when we're talking about mechanisms, we're referring to any strategy, tool, intervention, process, technique, or activity that has to do with emphasizing and increasing the uptake of research-based knowledge. And the key word here is to look at diversity, the key word to remember here is diversity. The study identified over 40 different mechanisms in the literature, 34 different mechanisms suggested by researchers in their protocols, and 24 different mechanisms across the interviews. Mechanisms that were common across the data sets included briefs and bulletins, executive summaries, leveraging networks, journal publications, presentations, and research days. I'd hasten to add that when you look at this, don't think of these as the best way of translating knowledge, because researchers should be very careful considering who they are aiming at and how they're going to get their message so that they can see the specific, before they choose their specific KT mechanisms. It's also important to note here that of the 100 protocols that were sampled from the NHRD, only 64 included a dissemination plan. That means more than a third of researchers made no consideration for how they would share their research findings in the planning phase of their research projects. This, I think, demonstrates the need to foster greater accountability and awareness on the part of health researchers in developing, reporting, and disseminating their research findings. In terms of health pathways, we have a look at knowledge translation pathways. We had a look at both formal and informal pathways, and these exist in the province. The formal pathways were identified in the policy documents And they include requirements for researchers to feedback their policy within 6 months of the completed research. And this includes an electronic feedback form, which needs to be sent back to the Provincial Health Research Coordinator. More informal pathways included annual provincial and academic research days, the Health Policy and Systems Research Journal Club, and the informal networks and relationships that have been fostered through prior collaboration engagement over years. Okay, but now moving on from that, let's have a look at some of the facilitators for knowledge translation in the province. And here we've divided these into 3 broad themes. Firstly, organizational capacity, culture and leadership, the characteristics of available research, and the relationships and networks for KT. Organizational capacity, culture and leadership. The Western Cape has steadily increased its capacity over time to demand, generate and use research through the creation of the multidisciplinary PHRC, consisting of both researchers and policymakers, and by seeding public health professionals and registrars within the Department of Health. This has increased the absorption capacity of the Department of Health, not only to source relevant information for decision-making, but also to generate its own research. And the health impact assessment has been key in this, as is demonstrated by some of these quotes. I particularly like the second quote, that they've got people in the province who are specialists, so ask them what the facts are. There, the Western Cape is very fortunate. That is different to any other province because they acknowledge the contribution public health professionals can make to decision-making. They've created the platform. They often go in, they don't even need to go out, and these are very smart, experienced people. This capacity has been sustained and nurtured by capable and motivated leadership at multiple levels of the health system. On average, most of the policymakers who were interviewed had been in their posts for 3 years, and together had a cumulative experience of 93 years working in the public health system. This combination of people and process has really created quite a strong pull from the Provincial Health Department for research-based knowledge and helped foster a culture that is pro-learning and open to the use of research in policy. Having a look at the characteristics of available research, we see here that some of the characteristics that are influence the knowledge translation in this province are the availability of credible research, demonstrating consistently strong positive results, that research that's generated by trustworthy and experienced researchers, a research message that is packaged and communicated to a targeted audience, offering feasible solutions with our research, and impacting policy with an accumulated body of work rather than one study. Additionally, researchers' motivation and responsiveness to policymakers' needs was also associated with producing research that was not only needed, but also more likely to be used. Having a look at the relationships and networks for KT, we all know that old adage is not what you know, it's who you know, and that is still relevant here. The success of knowledge translation hinges on mutually cooperative and trusting relationships between researchers and policymakers, but also the opportunities and spaces to foster these types of relationships. The collaborative forums, such as the Provincial Health Research Council, more informal Health Policy and Systems Research Journal Club, and the annual research days appear to be a key development of such relationships in the province. In particular, the Journal Club was noted by all researchers and policymakers as a unique approach to facilitating networks and collaborations, but also for knowledge brokering. Recognizing the value of the Journal Club for influencing policy and nurturing and personal development, this policymaker noted that for us, the Journal Club has worked well. And you know, we've been doing that Journal Club for 4 or 5 years, and we've sustained it because we benefit from it. We learn so much. And it's funny, the things that we learn there find themselves into policy documents. They find themselves into the way we do things. So it kind of feels like it's our time to just go and learn. It's a development thing. And I think what's quite interesting about this quote is not only the buy-in of this policymaker, but also the ownership of this process and the space. Over time, these spaces have created a dense network of researchers and policymakers that branch across institutional boundaries, and they facilitate personal relationships that allow policymakers to just pick up the phone, which was reported in quite a few of the interviews, to call a researcher that they know across different research institutions and ask them about their research needs, about their evidence needs. However, before you start to think that this all sounds a little bit too rose-tinted, there are some specific barriers that need to be addressed. The first of these are resource constraints, especially in terms of funding and time. Research constraints are a critical barrier to knowledge translation in the Western Cape, but also across African health systems more widely. Knowledge translation is a time-consuming and resource-intensive endeavor, and without specific investment, it's unlikely to be successful. Unfortunately, it appears that very few researchers consider KT activities in the design of their studies, and only 5 of the 100 studies actually included costs for KT in their budgets. 4 of these studies were for publication of, for printing of posters and for journal publications. The resource constraints can also mean a greater competition between research institutions, which in itself can impede knowledge sharing and potentially fragment the engagement with policymakers. Additionally, it increases the reliance of these institutions on donor funding and places researchers in a difficult position as we continue to wrestle to maintain our financial viability, meet the demands of donors, guide the research agenda, and all the while producing quality, well-needed research, high-quality, relevant research. The second barrier in the province has to do with system and priority misalignment. And despite the strong links across institutional boundaries discussed earlier, the provincial health system and the local research system remain mismatched in terms of their priorities, their incentives, and their timelines. Access to contextually relevant research was reported as the second greatest barrier for senior policymakers and greatest barrier for policymakers across Africa. While there is an abundance of research activity happening in the province, there are concerns about its relevance. As this senior policymaker noted, for us, it's not so much about having access to research. We have access to too much of it. It's about what is relevant and how do we engage this richness of ability and streamline it into something that meets the needs more effectively. I think this really highlights the need to have a good long think about how we are also looking at our own research priorities. In terms of incentives, this is a bit of a paradox. Researchers are incentivized to generate and translate their research by funders who frequently require journal publication as a measure of outcome. Most government-funded institutions in South Africa are measured this way. However, most government departments and policymakers do not have access to these journals and end up asking researchers to pass them on. This has led to researchers prioritizing journal publications over other potentially more successful KT mechanisms, as is demonstrated by this quote here. So long as the funders' demands command the pipe and the tune that researchers dance to, there will likely remain a mismatch between researchers and policymaker priorities and incentives. And then there are the differing timelines. Good quality, rigorous research takes time, which does not always fit in with the immediate decision-making context of policymaking. Although this is a bit of an intractable problem, there are novel methods emerging, including rapid review services and research repositories that promote faster access to good quality research. Looking at the third barrier surrounding issues of politics and power, we have to acknowledge that the development of public health policy is a political process. In the mapping of knowledge translation literature, politics was noted as a key hindrance to knowledge translation across African health systems. And in the Western Cape in particular, political dissonance between national and provincial government has made it difficult to align interests and ideas. As one policymaker noted, we have an early adopter status of taking the global picture and moving towards people-centered systems. Here, where we go internationally, our thinking in terms of what we do in this province is on a par of what the thinking is globally. That's not the case with the rest of the country. We have a clash in paradigms. Okay. Adding to this is a strong recognition that policymaking is not value neutral. Different values can result in research being taken up or not in ways that were originally not intended, as this quote demonstrates here. Policy is not value neutral. It's value driven and value laden. You take the same policy and you give it to somebody else and you've got a different set of values, a different political and social dynamic. And you use the same things, but you come out with different conclusions. Power dynamics rooted in issues of resource distribution, governance, and personal capacity also combine to influence what research gets translated and by whom. Expert interviews highlighted how experience and seniority of both researchers and policymakers determine influence in policymaking, as well as the access to resources to even do KT, including the time and opportunities to build relationships with policymakers. A unique view of one researcher that corresponds with the contextual issues we reported earlier was that the power to translate one's research remains rooted in individual positions within academic hierarchies, and that these hierarchies remain shaped by South Africa's socio-political history. But now that we've covered some of the KT mechanisms, barriers, and facilitators, let's turn to research use in the province and see if it's actually being translated, and if so, how. Unfortunately, there is no clear answer to this, as there is no distinct outcome or impact measure for knowledge use in the province. None were identified by the protocols or relevant policy documents, and most researchers reported being very unclear about what happened to their research post-dissemination. This is a widely acknowledged issue in the knowledge translation literature, and there are ongoing attempts to define and measure research impact and knowledge translation efforts. A common model used to describe the research use in both mapping of literature and expert interviews was that of Carol Weiss. Proposed in 1979, this model describes conceptual, symbolic, enlightened, and instrumental uses of research. Researchers reference this model when describing how different types of public health research appear to influence policymakers. Clinical guidelines very instrumentally used, even though there is a lot of symbolic use as well. But in clinical guidelines, you will very directly see the use of evidence because it's referenced. HPSR, for me, uses evidence in what Carol Weiss would call an enlightenment manner. So it's not always directly obvious that a policy may be influenced. Conceptual and symbolic benefits of HPSR research was also described as enlightening policy dialogue and infusing policymakers' thinking. And I think this suggests variations in the way different types of public health research are used, and potentially also different efforts by these disciplines to translate their research. But what does this all mean? Firstly, systematic understanding of context matters. Like research impacts, context is one of those widely described terms, but very rarely defined. The study has attempted to provide a detailed review of the Western Cape context as it relates to knowledge translation by systematically describing broad socio-political factors, national and provincial health system organization, and local health and research system challenges. A systemized understanding of contextual factors is fundamental to fostering knowledge translation, as it facilitates the identification of contextually relevant mechanisms for targeted audiences, as well as adding clarity to the underlying motivations for research use or the lack thereof. Routine mapping by researchers and policymakers of contextual issues can assist in determining who, where, and how research should be translated for best effect. Secondly, knowledge translation requires systems thinking. Like the complex adaptive system it's trying to influence, knowledge translation efforts should foster dynamic responses to deal with shifting context, relationships, and the research itself. In the Western Cape, relationships between researchers and policymakers have evolved over time and highlighted the need for trust, credibility, open communication, mutual respect, and sustained leadership to foster knowledge translation. In these relationships, it is these relationships that will likely support the better integration and alignment of health and research systems in the province. However, even in high-income countries, these relationships are weaker than expected and have led to calls for a learning health systems approach that integrates health service delivery with the generation of new knowledge. Such learning systems have been recognized as being responsive to change, achieving greater absorption capacity, and are more resilient to sudden health shocks. They require long-term collaborations and streamlined research and policy processes. Individual responses to knowledge translation should also recognize the complex adaptive nature of health systems decision-making. And as one policymaker noted, you can never say that you know it all, or that you have the answers. You have to listen and learn and be a student of the system. Thirdly, there is much potential for an embedded approach for KT. Embedding of health system requires linking researchers and decision makers in a system where the latter understand the value of evidence in informing their decisions, and the former are positioned to be able to provide timely and relevant evidence to inform each stage of the policy process. In the Western Cape, organizational embeddedness of provincial health specialists within the Department of Health and links across institutions have fostered collaboration and co-creation of health research and strengthened research policy networks. It has also enhanced the ownership of research by provincial health policymakers and developed institutional capacity to integrate research into the policymaking process. Additionally, an embedded health research approach has been shown to be a useful strategy for addressing the power dynamics that are often prevalent in low and middle income settings, and an important method of health system strengthening. Findings in this study suggest there is much potential for an embedded approach within the Western Cape, but facilitating greater opportunities for both formal and informal interactions between researchers and policymakers will be a key strategy to foster this going forward. Lastly, the study highlights some of the ethical considerations for KT. Policymakers have an ethical responsibility to ensure their decision-making is informed by the best available evidence, while researchers are ethically responsible for ensuring their research findings reach their intended audience so that the correct action can be taken. Interestingly, many of the studies registered on the National Health Research Database included their KT strategies under the ethics section of their protocols, suggesting that there is some awareness that knowledge translation is an ethical issue. The second ethical consideration excuse me, highlights the need for good research practice to extend to knowledge translation. If KT activities continue to be tagged on to the end of the research process and planned for only after the time frame and budget constraints are completed, then it's highly likely that we will continue to see the persisting gap between knowledge and policy. The final ethical consideration concerns the inequitable distribution of knowledge production across the province. And here I'd like to show you a graph showing the location of the samples that were studied across the Western Cape. Although the process of research distribution was viewed as mostly fair by researchers and policymakers, we can see here that there's a strong persisting high density of research in urban versus rural districts. Not only does this place an unnecessary research burden on already overstretched and research-saturated urban facilities, but it also provides a skewed picture of health systems functioning. There is a danger that decisions based on research conducted predominantly in urban facilities do not consider the unique challenges of rural settings, nor do they give a whole picture view of the health system. Given the systems and equity-orientated nature of current policy and provincial policymakers, the equitable distribution of research across rural and urban facilities will be an important goal going forward. Research grants that target rural areas can help stimulate a shift towards more rural-focused research, while regular mapping such as this can help policy decision makers monitor their progress. So in summary, this study has aimed to meet the need for an increased contextualized understanding of knowledge translations in African health systems, and specifically the Western Cape. It has highlighted how different public health disciplines vary on their influence on policymaking and therefore policymaking in the province. It proposes lessons that are likely to resonate with other low and middle income settings, including the need to review KT as an ethical and systems issue and to consider the potential of an embedded approach. As researchers, we have to recognize that achieving academic impact is not the same as achieving social impact, and that the adoption of new knowledge is neither a spontaneous achievement nor a foregone conclusion in health policy. But as this quote from the Health Systems Global Thematic Working Group notes, with the right level of support and interaction between researchers and decision makers, the translation of research findings into actionable policy and programmatic guidance is an achievable goal. I'd just like to say thank you very much to my supervisors for getting me through the last year and a half of research, and also to the policymakers, researchers, and members of the HIA who facilitated a lot of access to the information we used in the study, and also to these funders. Please help yourself to some cake before you begin. Thank you very much, Amanda. Excellent presentation, very clear, and lots of interesting stuff in it. We've got a variety of people in the room from different perspectives, be they research perspectives or policy and managerial perspectives, and I invite your comments, reflections, questions to Amanda on what is a really important area of work. And if you don't have them, I'll pick on them. Oh, hi, yes.
So it's excellent. It's lovely to see a real deep dive into understanding the process of knowledge translation. I was just wondering about two issues which impact us. And the first is really this distinction between the national and provincial agendas and how to manage that. Because essentially, we have major research from the Western Cape completely ignored by the National Department. We weren't contemplated. And with the result that actually we only do our formative work here and we do large trials outside of the Western Cape. So I was wondering whether that came out.
Very much so, yes. Sorry, do you want to finish and then I'll answer?
Yeah, and then the other question is just for what we've noticed with the questions, the type of questions the policymakers want to ask, is that there's almost like a 5-year, knowledge translation is a 10 to 20-year game. Yeah. And obviously that is not compatible with any donor funding cycle or any political cycle. Sure. So did you pick out in your, were there any starting reports of understanding how those questions change over time? often our work, the initial questions is how do we optimize intervention? Of course, this is a great idea. We want to do this. How do we optimize intervention? And then 5 years down the line, when the budget is being reviewed and continuing funds for a program, there wasn't a fly-by-night. That does this actually work? Yeah. So the questions are totally different. And so I was just curious to hear whether that was
So I think, both of those things definitely emerged, and I think particularly the issue regarding donor timelines came up, because I think, and that came up from researchers and policymakers, because they both recognized the fact that researchers are really sort of torn in multiple directions and needing to meet these various issues, and the fact that they are determined by donor funding doesn't necessarily promote relevant localized research that they need. But at the same time, what did come through quite clearly was the fact that in order to achieve a mutual goal that the researchers and the policymakers have, was that need to collaborate. And so that it did come through quite clearly that we need to actually start planning, sort of horizon scanning, planning together and looking how we can actually develop projects that not only that can motivate to donors for being longer, extending the donor funding cycle, but also to be a bit more meet local needs. I'm still also.
Letitia, I wonder whether, in a way, in thinking about your question, there's also an issue of how we can, as a collective, researchers, managers, policymakers, think together about the sorts of cycles that we go through. And there are differences in our cycles, but if we're actively interested in working together, being aware of those differences and how to manage them, in some way, it might be something we could think about. And maybe I'll throw that out to others in the audience to think. Sometimes we focus, Katie, on the research and but maybe there's a way of building an environment that enables it.
And then, sorry, just to go back to your original question about the national versus provincial, that was definitely something that came across with, and it was a key frustration for the policymakers. They say time and time again, we've got the stuff, we want to take it to national, but the doors are closing. And I think that also just indicates sort of that dynamic changing nature of policy making and how responsive we need to be to that. And through that horizon scanning again, just making sure we use the opportunities that come ahead. But it was definitely something that was recognized, that there were sort of these spaces that sort of opened, and in the glory days of 1990, 1994, when please policymakers, researchers, come in, give us your ideas, that space seems to be closing. And one of the policymakers specifically talked about sort of pushing those doors back open and needing to get back in there. Sorry, Jason.
No, sorry, thanks.
Yeah.
So thanks very much. Excellent presentation. The intra-provincial inequality is true, but when we looked at the review of research conducted in the province, it was actually ameliorated when you look at the population size. If you look at the number of studies per population, it's bad, but it's not quite
as extreme as that, yeah.
I've got two questions. So one thing struck me that knowledge, the translation is all in relation to health services and the state. So one of the experiences I had was being interviewed for a documentary that was made about farm working conditions, and all my research around farm working, was published or put to the state. But that documentary was much more effective in translating it actually, because similar line a state providing services actually Sweden, the Scandinavian countries basically stopped the imports of alcohol from South Africa based on the evidence presented in the documentaries. I wonder if there was any thoughts about who does the translating.
Absolutely.
My other comment is about the priorities from the policymakers' point of view. I wasn't sure if you were framing that as sort of a unidirectional flow, because sometimes the policymakers will not be aware of things that researchers bring to them. And it's actually in a way, if there's a dynamic interaction, then sometimes it can open ideas that people carry on doing what they've been doing, but they're not aware that they could be doing something else. If it's all reliant on what they say they want, you don't get that.
Absolutely, and I think what you're speaking to there specifically occurs a lot in those sort of informal spaces of interaction and collaboration, and really emphasizes the need for ongoing engagement, not engagement just for the duration of a research project, but that sort of ongoing facilitation and interaction and informing each other's decisions. And if I go back to that research flow diagram, it is bidirectional, that information is flowing, but it's happening through these formal and informal pathways, and I think that's something that we need to maybe be a little bit more aware and intentional about. Going back to the use of the documentary, without a doubt, the diversity that we have in terms of the mechanisms we can use have to be targeted to our audience. And sometimes it is luck. Sometimes we just hit the right place at the right time, the window opens and we're using the right tool for the right people and it gets seen by the right people. But there is definitely that issue that came through very clearly about who is the messenger and what is the message and what medium are we actually translating this message into. So yeah, absolutely.
Lady?
Thanks so much, Anna. It was a wonderful presentation. I just wondered, on the research side, when you had spoken to researchers, I think it takes an extra set of skills that might not come naturally just with good research skills that would allow you to go beyond the research into the processes of engagement as well as packaging it in different formats as you have just intimated now. And I wondered if there was any mention of anything being different now to a few years ago, where in most of the academic environments now, there's an obligatory obligation on academics to demonstrate social responsiveness in their work, and that was not the case a number of years ago, where you might not have explored it. I just wondered if anything had come out in that regard.
So we didn't explore that specifically, but one of the things that did come out was the fact that researchers are more willing to put their research out there than to talk to each other about their research. And I think that was a key issue that some of us probably still experience. And that was something that was raised by some of the researchers, that competition for resources perhaps, or prestige, or history, that those relationships sometimes don't facilitate information out before they facilitate information across, which can really fragment the translation of that knowledge and can confuse policymakers as well, because they're receiving different messages from different experts. So again, I think it really highlights that need to get back together and talk to each other. To speak to just what you said first about the energy that it takes to do knowledge translation, I don't think this is something that can be underestimated. It does require time, it does require investment, but if you do it prior to your research planning process and you incorporate it into your timelines and your budgets, you've got a much better chance of actually achieving success than thinking, oh sure, but I've finished my research project, funding cycle's out, I've got to apply for the next funding, but let me quickly publish this article. And that you think is your sort of your social impact. It's not. There are other ways, and there's a very interesting sort of new rise of this knowledge broker, which is a specific individual who is becoming a part of research processes used to build relationships strategically and use at the end and during and before in the planning phase of making sure that this research reaches the people that it's supposed to. So I think that knowledge broker position is something that's worth exploring. It could be part of your researcher role, but it might also be a separate individual.
That's okay. Thank you very much. I have many thoughts, but I'll just focus on two. So the one is I thought it was really interesting when you said you couldn't find evidence of the researcher, the protocols having direct
impact outcomes, yeah.
And partly I thought it was interesting because I sort of think if I think about policies that I know in the Western Cape, I can think that the policymakers would refer to a particular piece of evidence, and I'm thinking about like primary care 101, or I'm thinking about like the Zweigenthal sort of thing. So I think that's quite interesting. That would be interested to sort of do a mirror of this, where you actually look at all of the policies and sort of see, well, what are they saying? Is the evidence that they use to build it? Yep. But the other thing is a little bit more of a most research has null results. It's a very big problem in social psychology. It's a very big problem in the behavioural field. They effectively find any are very small. I don't know how you manage that, because policymakers are really excited about having evidence and being well, but when you have a null result and they're like, but we've invested our time and our effort, we need this thing to work, and you don't get a result, I worry that you still see those things implemented, but then actually when you go back and you look at the evidence isn't there. Yeah. And I don't know how policymakers and researchers manage the fact that actually the input to output ratio isn't great for a lot of the research that happens.
And I think that's one of the things that has to be negotiated a lot. One of the researchers specifically spoke about an exact case like that, where she said that we had our primary outcome showed no effect, but it was so taken on by it was a school health program, and it was so taken on by the school nurses, the school, they begged for the program. So she had to almost convince them, no, this is actually not something we can continue, because it's actually not something that in the long run effective. So, and again, I think that's what's important, is that ongoing discussion, because without it, you're not going to be able to negotiate those difficult situations.
So that point, Kirsty, raises to me what research is. I'm thinking null effect. What's the relevance? Maybe I don't do research. But I also thought it was quite interesting, Amanda, that you spoke about that there are a variety of types of research and different ways of thinking about impact.
Yeah.
And I also thought it quite interesting, and I make no significance about this, that the only researchers who actually responded to your request to be interviewed were health policy and systems research. So maybe we just actively worry about the translation.
That also has to do with gatekeepers.
I'm going to go behind you first.
Yeah, I was actually tapping onto that comment about your methodology and about kind of if you can share some lessons learned, trying to engage people like that, which are apparently really difficult to engage, and what you would give us like tips or tricks for future researchers who try to do the same.
To get the same. I think, first of all, we are incredibly lucky. If you want to do research with local policymakers, they were incredibly open to it. Not only in terms of what type of research, but also to feeding into it. So policymakers in the province at this time, I will say, because things do change and they shift, this is a good opportunity to get in there. They have very much an open door policy. Obviously, their schedules are quite constrained, so they were quite happy. So from a policymaker access point of view, I was actually quite surprised. I was knocking on some high corridors of power and they opened, and that was quite exciting. Regarding researchers, people are busy, and we have to acknowledge that. How many requests to participate in research we all receive via email a day, and that's fair. But at the same time, I think it is interesting, the use of gatekeepers are incredibly important. And again, I relied quite heavily on the networks of people who were far more experienced than me, and that tended to open doors. So I think leveraging networks and relationships cannot be underestimated, not only for access, but also for knowledge translation. So yeah, that for me was definitely key.
Thinking through this null effect problem. I mean, I think it is very difficult because trials themselves are quite reductionist in terms of having a single primary outcome. And as a policymaker, you're not really interested in one headline result. You're interested in sort of the whole process of what actually the small effects were and how those accumulate. And so one of the things, if you look at EPOC in Cochrane, the median effect size for effective interventions is 6%, which is really small, so it is difficult to show differences. And I think that one of the ways that we're going about doing it is we're trying to say, well, okay, if for example, in trial we're currently got underway in the West, for example, which is around depression care and viral loads. The viral load is much higher than the depression rates are higher than expected at baseline. So we're not expecting to show a difference. So what we have done now is we can say, well, we've actually expanded access to mental health services that was very needed population massively. Have we at least done that now? Okay. So we are putting in a non-inferiority secondary analysis. So that is one way. And then I think the interpretation of trials in terms of how pragmatic or explanatory arms is very nuanced, very sophisticated. There are very few people who do it. Policymakers don't have that skill set. And so it really is the responsibility of researchers to, when they actually show their research to. I mean, the most useful trials are negative explanatory trials, because then you can say, okay, if it didn't work under ideal conditions, it's a non-starter.
Yeah.
And positive pragmatic trials. Okay? But actually, 95% of trials fall into that categories. So I think we do need to grow that skill set amongst ourselves as researchers.
I mean, we think what Mara's talking about. I think in public health research, very often we fall into the same trap as development studies, where people very rarely publish things that don't work. And both from the researcher's perspective, but also from the policymaker's perspective, people very rarely publish on implementation failure or on programs that didn't have the impact that they're supposed to have. And that's part of our own, it's our own mode of thinking, our own mode of working, and that might require both researchers and policymakers to have some level of trust, relationship, and engagement to enable the publication of that kind of study interest. And I think that links to the thing with the need for relationships and the need for embedded research. But I think one of the dangers with KT is that very often it gets focused only on advocacy of good results rather than any kind of sharing of knowledge about things that didn't work, didn't go well, need to be adapted. And I think it's on all of us to try and figure that out.
Maybe something to add to that as well is also the level of policymaker capacity. It's very difficult to go and report results like this when there's very little understanding of what and how research is done. So I think part of maybe our role is also into upskilling the people that we're working with.
I know some of those people in the room, and I think we need to be slightly cautious about how we talk about colleagues and what levels.
I don't think that's the case in this moment.
No, but I think
more broadly.
I think we have a danger. There is a risk as researchers to see the problem that side, and there's a risk that side to see the problem that side. And in fact, it's also how we talk to each other. And the institutional imperatives in research environments drive us in certain directions that preclude the opportunity to engage, as well as the institutional imperatives in other environments. And I sometimes wonder whether we shouldn't just talk about those institutional imperatives more to get a better understanding of what's shaping the way we do things and how we do things. Before we get into, here's our research results and are they having a difference?
Yeah.
Because you noted the point about accumulation of knowledge as being important. And that, I think, speaks back to your point, Laura, about how the cycles turn and people ask different questions at different points of the cycle. I certainly, argued one thing on one study 20 years ago, and I may be re-arguing it now, because the world moves around us, and sometimes it's I think, we as researchers need to continue to put forward valid evidence wherever our research base to new situations. Forgive me for pontificating. If anybody else wants to ask a question or make a comment. Yes, maybe.
There's one more thing that I think that struck me. So we are very lucky in the province with the relationships that we do have. As you said at the beginning, the province is really subject to policies that come from a national level, and so it puts, I think, quite a lot of provincial policymakers in a dilemma when they now become party to evidence that's contrary to what the national policy says, and the process of political engagement that requires for the province then to do something different to the rest of the other provinces becomes, and it has happened a few times. I think we can also not underestimate those, as Lucy just said now, those institutional imperatives, because of the different levels at which policy is made. It's not so easy to get those translations into national level policy processes. In this province, I think there's so much more of a chance because of the interrelationship that we do have.
Yeah, and Melanie, you're absolutely right. And what I thought was interesting that it was actually the policymakers who identified those sort of closing doors of opportunity at national level. It wasn't necessarily the researchers, and they were the ones who identified that researchers were getting less and less access to national policy-making processes. But it also highlights one of the quotes that I remember very clearly, where a lady talked about ethical compromise, having to negotiate all these multiple forms of evidence and national policy requirements and local policy requirements, and having to ethically compromise on her decision-making, which I thought was just quite an interesting term to use.
Marcia.
Thanks for the great presentation. Just a quick comment. I was reflecting on what is policy, and I was in an email conversation with colleagues about 2 days ago, just reflecting on a workshop we had held with 3 district managers or a series of senior managers from 3 health districts in South Africa. And we didn't actually present them with formal documents, but we presented them with key ideas from early stages of our research, and actually just created an environment through different types of techniques, like a thinking environment, for them to actually discuss these early findings themselves. So there was no, hard policy document that came out of that, but it was a 2-day workshop that promoted thinking and learning amongst those level of policymakers themselves. So I think that I mean, it's not just about getting it into a print document, it's also just about creating environments in which people can think and learn. And our research is not even totally
finished yet, absolutely.
Yeah.
And in fact, more so, because then when it is finished, you've created the environment that is actually more conducive to receiving the information. And those collaborative workshops is definitely one of the most used strategies that was reported in the broader literature. And it's certainly something I think although it's quite time consuming and requires quite a lot of resources, it's worth considering further. And I think one of the things that came out quite clearly was that the Health Policy and Systems Research Journal Club, what seemed to be one of those ongoing processes, because I think one of the dangers of a workshop is it's a workshop for 2 days and off we go, whereas that ongoing space to learn and to discuss in a very uncritical environment, whereas you're not using my research, is not even an option, where you actually can talk about it in an equal manner. It's very useful.
Great. Thank you very much, everybody. Amanda, thank you so much.